Good morning, students. Today, I will teach you about inflammatory bowel disease. Inflammatory bowel disease. It is a set of chronic inflammatory condition resulting from inappropriate and persistent activation of the mucosal immune system, driven by presence of normal intraluminal flora. There are two types of inflammatory bowel disease. One is Crohn's disease, another ulcerative colitis. Now, epidemiology. Age of onset. Both ulcerative colitis and Crohn's disease occurs between 15 to 30 years of age. Second peak is between the age of 60 and 80. Now, male to female ratio in case of Crohn's disease 1:8.1, and in case of ulcerative colitis 1:1. Prevalence of inflammatory bowel disease is higher in urban and higher prevalence in high socioeconomic classes than in lower economic classes. Risk factor. Among the risk factor, cigarette smoking is most important causes. The risk of ulcerative colitis in a smoker is 40%, more than in non-smoker. Smoking is associated with a twofold increased risk of Crohn's disease. Oral contraceptive use, increased risk of Crohn's disease. Appendicectomy, it is protective against ulcerative colitis, but is associated with the highest risk of Crohn's disease. Normal intestine is usually in a steady state of physiological inflammation, representing a dynamic balance between factor that activate the host immune system and another factor, host defense, that maintain the integrity of the mucosa and down-regulate the inflammation. Factor that activate the host immune system by luminal microbes, dietary antigen, endogenous inflammatory stimulus. Loss of this balance may be responsible for Crohn's disease and ulcerative colitis. Here is the picture of Crohn's disease and ulcerative colitis. Here is the picture of normal colon. Here is the picture of ulcerative surface and thickening of colon wall, continuous inflammation. This is ulcerative colitis. And here is the picture of Crohn's disease, where thickening of colon wall, cobblestone appearance, and fistula formation. Now, Crohn's disease and ulcerative colitis results from the combined effect of alteration in host interaction with intestinal microbiota, intestinal epithelial dysfunction, aberrant mucosal immune responses, altered composition of GIT microbiomes. It also results from unregulated and exaggerated local immune response to common cells in the gut in genetically suspected individuals. Microbes exaggerated immune reactivity by providing antigen and then inducing some co-stimulator and some cytokine, of which contribute T-cell activation. Now, as we know, it's an idiopathic disorder. The exact trigger for inflammatory bowel disease is not known. Present evidence suggests that inflammatory bowel disease represents the outcome of the following interactive factor. Those factors are genetic factor, environmental factor, host factor, and lastly, psychosocial factors. Genetic factor. Genetic factor both are familial and susceptibility genes. Familial inflammatory bowel disease is more common among relatives of patients with inflammatory bowel disease than in the general population. In case of Crohn's disease, genetic factor plays a predominant role. The concordance rate for monozygotic twin is about 50%. Genetic factors are less predominant in case of Crohn's disease. The concordance of monozygotic twin is only 16%. And concordance rate for dizygotic twin for both Crohn's disease and ulcerative colitis is less than 10%. Now, susceptibility genes. Genes associated with immunity and autophagy. Those are named as NOT2 or CARD15, ATG, 16L1, and IRGM. NOT2 is act as an intracellular receptor for protein synthesis, and it is a 16L1 and IRGM. Both are associated with process of autophagy. Their actions are prevent entry of microbes into the wall of intestine. It regulates the innate immune responses. It also prevents excessive immune response against luminal microbes. Defective NOD2 or CARD15 genes. It is produced due to mutations, and mutant form are less effective at recognizing and combating luminal microbes. Defective NOD2, it allows the entry of luminal microbes into the lamina propria of intestinal wall and stimulate the inflammatory reaction. Two other genes, namely ATG, 16L1 and IRGM, are involved in the recognition and response to intracellular pathogens. Now, coming to environmental factors. It includes both the local microenvironment and the nutritional microenvironment. That is intestinal microflora or microbiota or smoking. Intestinal microflora. It includes some hygiene hypothesis, improved food storage conditions, and decreased food contamination and inadequate immune regulation. Smoking. Crohn's disease patients are more likely to be a smoker, and smoking exacerbates Crohn's disease. In contrast, an increased risk of ulcerative colitis is observed in non or ex-smoker. Intestinal microflora. In case of hygiene hypothesis, I want to tell gut lumen contains some bacteria, and its composition within the individual remains stable for several years. The intestinal microflora can be modified by disease and diet. Inflammatory bowel disease is associated with the alteration of these microbacterial flora. Improved food storage condition and decreased food contamination. It has reduced the frequency of enteric infection with a clean environment in the intestinal colon, intestinal lumen, and the immune system may not be exposed to microorganisms, followed by inadequate development of regulatory process to limit mucosal normal immune response. Inadequate immune regulations. The unstrained immune system when exposed to normal commensal bacterial antigen, which leads to inadequate immune regulation and allows pathogen to produce an aggressive immune response. And this uncontrolled inflammatory response in genetically susceptible individual occurs. Now, host factor. It's about epithelial defect and defective mucosal immune response. In case of epithelial defect, impaired mucosal barrier function, it is observed in inflammatory bowel disease, and it activates innate and adaptive mucosal immunity and sensitized individual to this disease. And abnormal intestinal defense, we know Paneth cell granule contain antimicrobial peptide, which term as defensin. It normally protects the mucosa against adherent and invading the bacteria. These abnormal defensin are found in Crohn's disease, those patients having ATG16L1 mutation. Now, defective mucosal immune response. There are normal regulatory immune response of gut mucosa. It is very powerful and prevent inflammatory response against the dietary antigen and bacteria. And defective regulatory immune response in a genetically predisposed individual, this response is defective, which leads to abnormal immune response. Now, psychosocial factor. It can contribute to worsening of symptoms in inflammatory bowel disease. Major life events such as illness or death in the family, divorce or separation are associated with increase in symptoms such as pain, bowel dysfunction, bleeding. Thank you.